Hi, thank you very much. So this afternoon, after Yak's presentation, I'll be talking about another interesting case that we saw in June of Measles Encephalitis. So to start with, 3 weeks ago, there was an article that was published in one of the news outlets stating the rise of measles cases in South Africa. And in October last year, the Western Cape government actually published that there's been a dip in the infant immunization coverage to 67%, particularly in the Western Cape. And that's a 25% drop from the WHO recommended 95% coverage. And to cement that, the NICD does produce weekly situation reports on measles and rubella. And there's a report that was published on the 20th of July, so that's just 11 days ago, which showed that in the last 3 weeks before the date of publication, they had documented 590 measles cases just in South Africa. And of those, 171 were actually in the Western Cape. So we definitely know on top of it. And so I can't talk about measles CNS infections without talking about the well-known publication that we had during the 2009-2010 measles outbreak. That was, Prof. Ty was part of it, where they published a case series of 8 cases between July and October 2010 of individuals that had advanced HIV, basically, with a CD4 37, and between the age of 14 and 38. And these cases were individuals that had measles encephalitis, or they presented with a CNS sort of syndrome, and a few of them had a positive measles PCR that was tested either on CSF or brain biopsy. The mortality was quite high, 100%. During the time of the study, it was roughly around 86 of the 8 cases had died during the time that the patients were seen in the hospital, but the 2 other individuals later on also demised within a period of 6 months. And so the case that we saw was a 45-year-old male. He was HIV negative. And what we know is that in 2019, he was initially diagnosed with an atypical chronic lymphocytic leukemia. He received 3 cycles of chemotherapy, had a good response, and went into remission. Unfortunately, during COVID, he was lost to follow-up. So there's no trace of his clinical information with the hematology team. So then he later presented in March 2026 with the symptoms worsening splenomegaly and pancytopenia. A repeat bone marrow showed that the patient had a splenic B-cell lymphoma. And at that time, he was restarted on the chemotherapy protocol that included rituximab. So then in May, he acutely presented to the EC with seizures, which were initially focal. And then later on, during his admission, became grand mal seizures requiring ICU admission. He also had a preceding headache. But otherwise, there was no rash or any history of a pneumonia. He had 2 children who were in the teens and were otherwise well. So at this time of presentation in May, there were 2 possible differential diagnoses. Was this a possible CNS lymphoma in a patient who was already on chemotherapy for a lymphoma that was diagnosed in March, or was this an infectious cause? So to rule out that, there was no contraindication for a lumbar puncture, so a CSF was done, sent for cytology to try and establish whether there was lymphoma in the brain, but on the final cytology diagnosis, there were no malignant cells that were noted in the CSF, so perhaps at this point, we have ruled out a CNS lymphoma. We did, however, receive 3 CSF samples that were sent to the lab to try and rule out infectious causes. The first CSF was rather blunt. It was a cellular and slightly elevated protein of 0.5, negative cultures and molecular tests that were ordered. And then on the 1st of June, we received another CSF, slightly elevated protein, 3.16 lymphocytes, but otherwise cultures and molecular tests that were requested were also non-remarkable. And then on the 3rd of June, there was another CSF that was sent, which also more or less had the same cells in terms of the polys and lymphocytes. But I've noticed that there was an after request that was made by the neurology team on the same day, which was the 3rd of June, to add a measles PCR on the CSF, and the measles PCR turned out to be positive. What I'd like to mention is that on the 29th of May, the patient did have an MRI that was done, and from gathering information, the neurology team does meet with the radiology team every Wednesday, which was the 3rd of June, to discuss the images. And so the request was potentially made after that meeting. So these were the MRI images. I claim to know, but the impression from that MRI was that there was some abnormality that was noted on the frontocortical area that was not suggestive of hemorrhage. And from their assessment, they did not think this was PML. And so from that, with the imaging, the way the patient had presented, and a positive measles PCR, we had what I would call probably a definitive diagnosis of MIBE. However, the patient did have a rocky stay in ICU and later demised on the 12th of June. So as we reflect on this case, there are just a few questions that I'd like to pose. Audience, why is this MIBE and not the other serious complications that have been documented? And why was the CSF PCR positive, and what risk factors did this patient have? Because we know that from the case series that was published here in South Africa, the main risk factor was HIV, although there are other publications that have been published regarding MIBE in other parts of the world. So just bringing us to the virology of measles, it is a virus that belongs to the Paramyxoviridae family. It is from the genus morbillivirus. It's enveloped a negative sense RNA stranded virus. And of note, the most important thing that I would like you to note on the structure of the measles virus is that matrix protein, the fusion protein, and the hemagglutinin protein, because it will come in handy as we discuss the pathogenesis. And generally in the acute phase, measles is transmitted by respiratory droplets. It does basically fuse to the macrophages and dendritic cells that are found in the alveolar, and it binds to the SNAM receptors. And the macrophages then will carry it to the lymph nodes, where it will then be transported into the blood vessels and cause acute viremia, and therefore produce the symptoms that we know, the rash and everything else that we know about measles. And then later on, it goes back into the lung through the Nectin-4 receptors that are expressed by the epithelial cells, and that way it is then shed into the environment and then passed on to the next patient, and that's in the acute phase of measles. However, in some hosts, there can be complications such as diarrhea, otitis media, and in certain particular hosts, you also have CNS involvement, which is another complication of the measles virus. So why does the measles virus, why is it able to cross the blood-brain barrier? There are three postulates that sort of hypotheses of how the virus is able to do this. We know that generally measles attaches itself to the SNAM receptors, or the Nectin-4 receptors that are found in the lungs. And we know that the brain cells do not have any of these receptors. So there is a postulation that perhaps there are other receptors that have not yet been properly documented, that perhaps aid the measles virus to cross from the blood vessels into the brain tissue. Another possible phenomenon is the Trojan horse phenomenon, where the measles virus infects the monocytes in the bloodstream. And so as the monocytes pass through from the bloodstream into the brain tissue, it carries with it the measles virus into the brain tissue, and it starts to infect the brain cells. And lastly, the measles virus can undergo several types of mutations, and part of those mutations enable it to be able to cross from the bloodstream into the brain tissue without requiring any receptors. So we know that measles virus, in terms of the CNS complications, there have been four main phenomena that have been documented. You have the primary measles encephalitis, which is usually during the acute measles infection. You have the what I would call acute post-measles encephalitis or demyelinating encephalomyelitis. And then you have MIBE and SSPE, which is the subacute sclerosing panencephalitis. And of note is that on the horizontal axis is the duration in terms of when you would expect these CNS syndromes. And in the months and the years from the time of the primary infection is where you should have MIBE and SSP, and that's where it is believed that there is measles virus replication in the brain. So I'll just briefly touch through those four phenomena. So the primary encephalitis usually occurs in the acute infection, and this is generally in individuals that have not been vaccinated. So more so in children that have not been vaccinated. So this will happen more in children that have not been vaccinated. And basically the pathogenesis is that there's actually a direct neuroinvasion of the virus through infected lymphocytes, as I had earlier alluded, into the brain. And that basically causes inflammation, and there's like an intense immune response, and it can result in cerebral inflammation as well as. So it will affect children more than adults because usually it's in unvaccinated or partially vaccinated infants, and it presents with fever, seizures, and that will occur during the acute phase. And patients can also present with raised intracranial pressure. The biggest diagnostic marker for this is you will have an abnormal CSF, and generally you are able to find viral RNA in the CSF. And the neuroimaging will also show edema as well. It does have a fairly high mortality, about 10 to 15%, and 25% of the cases will have a permanent urological sequelae. Just keep on. All right, and then you get acute post-measles encephalitis. The reason why you call it acute demyelinating encephalomyelitis is that that syndrome itself can be caused by other viruses as well, such as varicella. And there's also been documentation of bacteria such as group A strep also causing that. But particularly, it's quite common with the measles virus. And usually this occurs about a week or two at the time of resolution of the acute infection. And the main thing about this pathogenesis is that it's not the actual virus that is causing damage, but it is a molecular mimicry where antibodies will attack the myelin sheath of the brain cells, like the oligodendrocytes. And so the biggest diagnostic marker is you could do myelin-based protein on CSF, but otherwise your viral PCR will be negative, or antibodies will not be raised in patients that present this. So this is in the acute phase, and so once the time starts to pass, there's definitely a shift in the virus. So as the virus persists in the host, it starts to mutate. And so on the right, you have a normal measles virus with those proteins that are highlighted, the H protein, the F protein, and you also have the matrix protein, which is surrounding the nucleic acid in the middle. And as time progresses, the measles virus, it's an RNA virus, therefore it's prone to error as it replicates. So it can easily mutate, particularly with the F and H proteins, which then result in it being hyperphysiogenic, and so allows it to spread from cell to cell without requiring any receptors. And the M protein also, in particular, once it's mutated, it makes the measles to replicate in a defective form, and so that also allows the virus to continue and persist in the host. So now brings us to MIBE, which is usually from months to within a year of the primary measles infection. It's a very rare occurrence, and it's usually defined as a complication that occurs in individuals who are immunocompromised. So patients that have impaired T cell function, leukemia, HIV, or post-transplant. Otherwise, the mortality is quite high, for about 75 to almost 100% mortality. And it is believed to be driven so much by this F protein mutation that allows it to proliferate in the brain. And lastly is SSPE, which is a very slow CNS complication of measles, usually in individuals that had measles in infancy and the virus became dormant in the brain. The virus will be able to seep into the brain tissue during the acute infection, but then The difference is that in these individuals, the virus becomes very dormant, and then there's a slow progression and a slow mutation of the virus until the final stage where the individual presents with CNS syndrome. So back to the outbreak that occurred in 2010, Prof. Dai also then took it a step further and tried to characterize these cases from a molecular point of view. So she sequenced four of the measles viruses that were picked up in the brain tissue biopsy or CSF. And what she found was that the virus that was in these patients was not very different from the virus that was circulating during the measles epidemic. And so basically what that means, it shows that there was a relatively short time between the time that the individuals got the virus to the time that they actually presented with a CNS infection, because they had very few mutations, therefore showing that the virus was the same. So in literature, there have been a lot of documented mutations, and just to highlight what I've already just said about the M protein and the F protein. So back to the case and the three questions that I posed. Why is this MIBE and not other CNS complications? Well, for starters, our patient is immunocompromised, so that sort of fits the picture because it's the one CNS complications that will be in immunocompromised host. And the fact that the PCR was positive, gives it a lot, adds more weight to the diagnosis of MIBE. And as well as the clinical presentation, generally these patients present with seizures. Why those measles in the CSF, we don't know yet, but there is a plan to sequence because we currently just postulate that there was possible mutations that could have occurred, as was already documented with the previous case, where there were mutations in the fusion protein. And as well, this patient was at risk because they were quite immunosuppressed. So we know that the cases that have been documented in South Africa were mainly patients with advanced HIV, but our patient was HIV negative. So another food for thought would be, is there a role of rituximab in this patient, because the patient was receiving a monoclonal antibody which would wipe out their B cells. And so we don't know yet, but there have been two cases that I found that were documented. The first one was actually a vaccine-associated MIBE in a 1-year-old who received a vaccine. And so the live attenuated vaccine is what ended up causing measles infection and later complicating to MIBE. And also a 26-year-old individual that also had leukemia and based on rituximab that did have measles CNS complications. So in conclusion, measles is in the acute phase. It will affect your immune cells, your macrophages and epithelial cells, but rarely you will find some spontaneous mutations that can occur and that can allow the measles virus to actually go into the brain. And so once it's in the brain, probably the virus being in the right place at the right time, what later follows depends on the host. So if you have a host with an impaired systemic immune response, you will get a rapid progression where the virus is able to rapidly multiply and cause symptoms in a fairly short period of time, and which would be in cases of MIBE. Whereas if you have an individual who has an intact systemic response, that progression of the virus is much slower, and that allows the virus to mutate even more, and therefore resulting in SSP. So the take home is that as long as we have measles in the community and we're not on top of it in terms of vaccination, we should constantly think about this case when patients present with seizures and you just can't explain or find a reason why they have this neurological presentation. And this gentleman did not have any typical presentation of measles. There was no rash, nothing that had preceded his CNS presentation, and that's just something to note because it was immunocompromised. So patients would generally present with a typical measles virus disease. And generally diagnosing CNS complications is very difficult. CSF is not always positive. So I think for this case, we were actually quite lucky. And obviously doing a brain biopsy in a live patient, it's always a bit risky. And so that's very difficult. And there is also no licensed treatment for CNS complications. So once the patient has it, it's more of just supportive care, hope that they survive without any symptom, but it's not the case. So.